Hi. This lecture is designed to talk about the theoretical frameworks that help our understanding of psychosocial processes in families managing dementia. Particularly, we're going to be talking about the stress response system and the theoretical frameworks that have been developed to help our understanding of the stress response. By families, we're not just talking about individuals with dementia and their ability to withstand the stress response, but also we're broadening our understanding to include those caregivers of individuals with dementia. In the lecture to follow this one, we'll be broadening our lens even further to include the physical environment in our understanding of psychosocial processes. So first, we're going to discuss what we mean by stress. What is the definition of stress? And what is the biologic stress response? This is important background information to help understand why the stress response is important in considering how people cope with the diagnosis of being given a dementia diagnosis, Alzheimer's disease diagnosis, and also how their family caregiver copes with that diagnosis. We'll then talk about several leading theories that describe the stress process from both a psychological and sociological perspective. These leading stress theories are important in a number of models of care that we test and that are important for informing your development of models of care. They're by no means meant to be inclusive of all the important theoretical work that's been done in this area, but rather to highlight several key examples. So what do we mean by stress? It's a physiologic response to a perceived or real threat, and it's designed to help mobilize our resources to survive that stressful event. And that results in a series of neural and chemical reactions that help us escape the stress or confront the stressor. A person experiences stress when the demands imposed by that threat exceed that person's coping abilities. And this results in the physiologic reaction of stress that then result in a consequence of disturbed thinking, emotions, and behaviors that can ultimately affect our well-being. Hans Selye was considered to be the father of the study of stress. And in the 1950s, he proposed the idea that there's a direct relationship between the chronic physiologic stress that we experience as part of daily life and the excessive biologic wear and tear that our body experiences. Hans Selye also proposed the general adaptation syndrome model that I'll briefly summarize here. It begins in 3 stages. First is the alarm stage. When we're immediately confronted with a threat, it triggers a series of events that mobilizes our sympathetic nervous system activity so that there's a release of adrenaline and noradrenaline. This raises our heart rate, raises our blood pressure, helps us prepare to either confront or escape that threat, and it's also what we call the fight or flight response. Next is the resistance stage. After a few seconds of our neurologic system activating the sympathetic nervous system, we now need to mobilize our endocrine system through the adrenal cortex to continue the release of adrenaline and noradrenaline. This enhances our ability to fight off stressors and maintain that moderate level of physiologic arousal so that we can continue to confront or escape that stressor. But this comes at a cost at other physiologic systems in our body intended for survival. And so in the resistance stage of our general adaptation syndrome, things like our ability to fight off infection and our compromised immune system occur. Finally, all of our resources are ultimately exhausted, and this brings about the disorders that we see as a consequence of long-term stress. In other words, that sustained or chronically high heart rate, sustained high blood pressure that was triggered in the alarm stage increases our risk for heart attacks and strokes. Another way to think about it is through these 3 phases of stress and how they explain the long-term consequences of an individual's ability to live with dementia or caregiver's ability to caregive for a long-term an individual with dementia. In the immediate stage of stress, again, mobilized within a few seconds of experiencing perhaps bad news, whether we can deal with a dementia diagnosis, our heart rate goes up, our blood pressure goes up, we may experience anxiety or an anxiety-like reaction. In the intermediate stage of adjusting to this stress, in addition to having that activated sympathetic nervous system activity, our glucocorticoids are also released by the adrenal cortex, which mobilizes our ability to sustain the energy we need to continue to confront this stress, but also has other consequences. And it's through this prolonged effect of stress, through the prolonged release of these glucocorticoids, that we see some of the consequences of a depleted stress response, our body's depleted responses and ability to confront and deal with these stressors, and some of the health outcomes that we observe. We've had over 20 years of brain research that has helped inform our understanding of how these prolonged exposures to glucocorticoids result in aging processes, not just aging processes of all of our physiologic body systems, but also aging processes related to the brain. And it's why we consider dementia to be a disease entity associated with an aging older individual. It's not true that all individuals with dementia only are in the older adult years. However, most individuals develop dementia-related illnesses in older adult years as a result of these prolonged glucocorticoid exposures. Prolonged glucocorticoid cause damages or shrinkage of brain tissues, as we've seen in earlier lectures, and this damage that occurs over a prolonged life course results in our risk for many chronic illnesses that are associated with impaired immune system functioning, prolonged inflammation response. This includes heart disease and other risk factors, and ultimately risk for dementia. There's been an abundance of research looking at how the stress response interacts and causes changes in behaviors in individuals with Alzheimer's disease. And this has been through animal models and human models. In this area, in this slide, we're looking at the hippocampal region of the brain, the primary region of the brain that is affected with the plaques and tangles that begin in the initial formation of the disease process. We see, for example, in animal models, where animal models have been genetically altered to have Alzheimer's-like disease, that when those animals are under stress, they're more likely to develop higher rates of more toxic beta amyloid plaques in the brain region of the animal, compared to animals that are not experiencing stress. We also see that individuals who have had a very long and prolonged stressful life course history are more likely to develop a more rapidly progressive and more symptomatic form of Alzheimer's disease. So there's different ways in which stress influences individuals with Alzheimer's disease, both in the formation of plaques and tangles, the pathologic hallmarks of the disease, and also explains how life course can influence the manifestation, particularly of behavioral symptoms and more aggressive forms of the illness. While an understanding of the physiology of stress is important when considering poor health outcomes that can result from the accumulation of stress over time, it does not help us understand why two persons exposed to the very same stress would experience the stress response and stress-related outcomes very differently. And so an attempt has been made to integrate the theoretical features of stress from both the physiologic and psychological conceptions of stress in an area called psychophysiology. This broadens Selye's definition and is an integrated approach that helps lead to an interdisciplinary understanding of stress among theoreticians, researchers, and clinicians, and demonstrates that there's a mind-body phenomenon going on when we consider the stress response. Folkman and Lazarus included a psychophysiologic perspective in their transactional model of stress and coping, and in terms of the coping that occurs after the appraisal of a stressful event, or in that an appraised stressor will elicit an immediate psychophysiologic reaction to that stress outcome. Looking at this simple model, you can see that there is a central tenet in that a potentially stressful event will trigger an appraisal process. First, there's a primary appraisal process in which the individual assesses whether there's the degree of the threat in relation to their well-being. If the event is perceived to be threatening, then there's a secondary level of appraisal in which the individual assesses their coping resources or their ability to manage the threat and challenge. And the ultimate coping response is initiated after these appraisals, and the eventual psychophysiologic stress response depends on one's coping and appraisal processes. In other words, this model posits that situations or experiences are not inherently stressful, but are experienced as stressful after this two-stage appraisal process by the individual. Initial appraisals are influenced by background, past experiences, culture, ethnicity, and personality, and the secondary appraisal process is more situation-dependent than this initial appraisal, and it's in that secondary level of appraisal that we target our interventions. Among patients with dementia, there's evidence that coping strategies that are confrontive or active can lead to lower levels of distress than avoiding coping. So let's think about this stress as given a diagnosis of dementia. The individual may appraise it as too overly stressful and a potential high level of threat, and therefore their coping decision may be to avoid thinking about it. That would not lead to as many successful outcomes as if the individual were to accept the news, appraise the diagnosis as something that they can work with and work towards dealing with, and that would ultimately lead to improved coping. The model's been also useful in developing family caregiving interventions, in helping caregivers appraise the stress associated with long-term caregiving for someone with dementia. And there's extensive literature showing that interventions directed at the reappraisal of the news of caregiving can lead to better outcomes and reduce negative consequences. I'm going to list here some of the potential interventions that have been tested. These effective interventions include things that are psychotherapeutic. There may be general education components to some of these interventions. And what's been found in the literature is that it's really multi-component interventions that lead to the best outcomes. You would expect that interventions that have mostly an educational component tend to increase the caregiver's knowledge about dementia, but may have less effect on their distress and burden. And a psychotherapeutic intervention may help with ultimate coping, but that a combined multi-component intervention really leads to the best outcomes. Len Perlin broadened this perspective of the stress process model to include a sociological perspective. This looks deceptively simple, this model, but it's relatively complex and comprehensive. In this model, he proposes that people's position in the social structure exposes them to stressor, which in turn leads to stress outcomes. His framework assumes that life stressors do not happen apart from social circumstances, and he postulated that there were moderators and mediators that would affect the relationship between that stressor in the blue circle to the outcomes, and that there was a broader social structure that affected these relationships as well. We can think about this model in terms of a person with dementia, in which the stressors refer to the negative symptoms of the dementing illness. The individual with dementia is coping with negative symptoms, which results in strains and psychosocial effects, which in turn then have outcomes that are associated with well-being. We've used this model in developing interventions for caregivers with dementia, and because it helps understand the unique demands and resources of caregivers. And I'm going to just show you a more comprehensive version of this slide here. For caregivers of persons with dementia, here we can look at the unique demands and resources of caregivers. In this expanded model, you can see that at the top of the slide, we're considering things like contextual context. Also in the model are the stressors themselves, and these are divided into primary stressors. There's also mediators of stress and ultimate outcomes. The primary stressors are those perhaps directly connected with the caregiver's ability to provide care. There's secondary role strains, such as those caused by competing demands, things like other outside work demands, caring for your family. There's secondary intrapsychic strains, and these can include the impact of caring on a person's self-esteem. So this framework can account for many influential factors, which can include the demographic, cultural, and life history influences, allowing for much more individual plans of care. The mediating factors include resources for coping with social, economic, or internal stressors, so we can think about the many demands on family caregivers. And it's been a very useful way of making sense of a carer's particular situations and suggesting areas for intervention. If you look at the slide, you can see a variety of hypotheses that can be tested and relationships that can be tested in developing interventions. What's useful about this model is that while it is deceptively simple in its original conception, it's quite comprehensive, yet easy to understand, and very clinically relevant. The third model I'd like to talk about was developed by Hall and Buckwalter, the progressively lowered stress threshold model. It's particularly useful in providing a frame of reference to understand the neuropsychiatric symptoms that persons with Alzheimer's disease specifically express. According to this model, persons with Alzheimer's disease have difficulty processing and responding to the external stressors in their environment, and that this ability to tolerate stressors in the external environment is reduced as an individual progresses from the mild stage to the moderate and then ultimately severe stage. And that these difficulties are a result of the progressive deterioration in our cognitive and functional abilities that accompany Alzheimer's disease. So the more advanced the Alzheimer's disease, the more the behaviors are typically present. And you can see to the left side of the slide, individuals have relatively high levels of ability to tolerate stress, but as the threshold is reduced, anxious behaviors are more likely to be expressed, and the stress threshold more likely to be exceeded, leading to a greater likelihood of dysfunctional behaviors. There are many internal and external stressors that could result in a person having an accumulated stress response on a daily basis, and these stressors tend to accumulate over the day and are thought to be the root of the behavioral disturbances that we talked about last week. A stress inducer could be an internal discomfort such as pain, fatigue, or hunger, or even unmet quality life needs such as the need for attention or intimacy or friendship. It can result from the person with dementia's impaired ability to communicate or express their needs, or their impaired ability to be understood. These stressors can also come from external sources such as environmental distractions or a very noisy environment or a very impatient or unskilled caregiver. And if we think about the typical day of a person with dementia, we can think that many likely stressors are likely to pile on top of each other. And it's really this accumulation of stressors over the day that can lead to some symptoms that we see, such as sundowning behavior in the evening or disruptions in sleep-wake cycles. So this particular framework has been very useful in thinking about caregiving, nursing interventions in a variety of caregiving settings. And we will discuss this framework and the other frameworks as they informed our models of care that we'll talk about next week. We'll also be expanding, as I mentioned, this framework and others when we begin to consider the role of the physical environment in part 2 of this lecture. This was a very brief overview of several important theoretical models, but I hope it definitely highlighted why theoretical models are important in planning care of persons with dementia. First, these models give us a framework for understanding the diversity of responses that individuals have to a stress process. It also gives us a rationale for guiding the interventions that we are trying to develop in our next 2 weeks. So this will provide a framework for us for informing why we need to develop the models of care that we're going to be talking about next week and the following. It also helps us design ways of evaluating whether or not these interventions are effective. How do we evaluate the outcomes of these interventions? And these theoretical frameworks help provide justification for that. And lastly, and very importantly, All the disciplines that are part of a healthcare team, we all bring a different language that we talk about. And theoretical frameworks help us come together with a common language that we can communicate when we need to get together to design the models of care. Thank you.